Committee to commence business. Those in favor, please say aye. Those not in favor, please say no. So the ayes have it. Good. Our subject matter specialists, technical staff from the Office of the Clerk, and also our esteemed stakeholders from the Epidemiology and Disease Control Unit at the Ministry of Health. I think you all have a copy of the agenda. Honorable members, we all have a copy of the agenda. Before going proper into business, can we look at the agenda and adopt it? And possibly make amendments where possible? If it is okay, can I have a volunteer to please move that we adopt the agenda? You move? Seconder? Yes, that should be amended. That should be amended. Yes. And the AKI, there is zero added to the AKI. It should be omitted. Yeah. So thank you very much. It is moved and seconded that we adopt the agenda with amendments. Those in favor, please say aye. Not in favor, please say no. So the ayes have it. Thank you very much, honorable members. SMS, technical staff from the Office of the Clerk. I welcome you all to our today's meeting. As the agenda dictates, today we are meeting officials from the Ministry of Health under the Epidemiology and Disease Control Unit. But before going proper into business, I would like to take this opportunity as procedure and practice demand, we introduce ourselves. First, I will start with my humble self. I am Honorable Ahmad Kama, the chairperson of the committee.
Good morning. I am Honorable Modulamin Bieber, the vice chairperson of the committee and member for Bani North.
Ablai.
Yes, my name is Honorable Epidemiology.
You can also introduce yourself.
Good morning, everyone. My name is Dr. Anna Jame. I work for the Epidemiology and Disease Control Unit. I'm the incident manager for the acute kidney unit and also the supervisor for the field epidemiology program.
Good morning, everybody. I am Ahmad Jallo. I'm the acting program coordinator for the Epidemiology and Disease Control.
Good morning, I am Balajasa.
Good morning. My name is Siri Fordao. I'm a field epidemiologist. I work with epidemiology and disease control. Good morning. I am also a field epidemiologist.
Good morning, everyone. No Hakuma is my name. I'm a field epidemiologist.
Good morning. My name is Malik Mani. Also a field epidemiologist. I work with epidemiology and disease control. I work as a person for AKI response.
Thank you very much. And we welcome you once again to our today's meeting. I can see that we are well equipped with epidemiologists because everybody said I'm a field epidemiologist. So it's not by mistake that we invite them, and then coming from the Epidemiology and Disease Control Unit too. So thank you very much. Honorable members, just by way of introduction, and then our esteemed stakeholders, this is the National Assembly Select Committee on Health, Disaster Refugees and Humanitarian Relief, and it is established by the general constitutional power to perform oversight over government operation and activities. Section 109 of the Constitution of the Republic of the Gambia, 1997, empowers the National Assembly to establish committees with the general mandate to inquire into the activities or administration of ministries or departments of the government. Committees may also investigate or inquire into any matter of public importance. The Select Committee on Health, Refugee, Disaster, and Humanitarian Relief was established by a resolution of the National Assembly in the 6th Legislature. The committee has the general mandate to examine such matters within its remits as it may determine appropriate or refer to it by the Assembly. And on the specific matter of the acute kidney injury among children, a resolution was passed on the 26th day of October 2022 by the National Assembly, mandating this committee to conduct a full-scale parliamentary inquiry into the issue. Both the Constitution and the standing orders accords each committee in the performance of its function all the powers, rights, and privileges as are vested in the High Court at a trial in respect of A, enforcing the attendance of witnesses and examining them on oath, affirmation, or otherwise; B, compelling the production of documents; and C, the issue of commission or a request to examine witnesses abroad. So we are well covered by the prevailing legislations of the land, that is the Constitution and that of our standing orders. On the issue of the AKI specifically, the Select Committee on Health, cognizant of its constitutional and parliamentary mandate, initiated a parliamentary inquiry as mandated by the General Assembly into the matter with a view of unearthing the truth and circumstances surrounding the unfortunate incidents and to advise the Assembly accordingly. The Portfolio Committee inquiry seeks to establish the cause or causes and the impact of the AKI, that is killing children in Gambia, and in particular inquire A, the root cause or causes of the reported deaths of at least 66 plus children; B, the effects of the contaminated medical syrups linked to the deaths; C, the impact of access to primary healthcare services on emergency cases, especially for children; D, the culpability of the suspected importers and the pharmacists linked to the contaminated drugs; E, the impact that the availability and access to medical drugs, especially for children, has on emergency health services; F, the effects of the prevailing legislations, the Pharmacy Council Medicine Control Agency, on the pharmacy licensing and medical regime of the country; G, to consider proposal for a review of the legal and regulatory regime governing the pharmacy, medical drugs importation, and stores and licensing administration; H, how the pharmacy licensing scheme is administered; and I, the effectiveness of the current measures being undertaken by the Ministry of Health to address the AKI cases and contaminated medical drugs; J, to draw on other international best practices and protocols, possible strategies, initiatives, and actions that the Ministry of Health should consider addressing the administration and impact of medical importation; and K, any other related matter. So the scope is specific but also open based on our mandate. That is by way of information and by way of introduction for our esteemed stakeholders to know. This is the mandate given to the committee, and then that's the reason why you are called. Not everything falls under your purview, we understand, but the matters that falls under your purview, we are interested to hear from you, your position with regards to the issues and the current measures you have undertaken so far. By way of procedure and then practice and according to our standing orders, any stakeholder who wishes to speak before the committee shall take oath or affirmation just to ascertain the clarity and also the veracity of the information you are giving us. And this is provided for in clause 103, subclause 6, A, B, and C of our standing orders, and also clause 103, subclause 7 of our standing orders. So I will now direct the Secretary to please administer the oath or affirmation to the stakeholders, whosoever is going to speak on behalf of you. If it is the whole team, we can do so one by one, but if it is specifically one person or two, we can also do so. Please help us.
Affirmation. I, Dr. Anna Jame, do hereby affirm I will speak the truth, the whole truth, nothing but the truth. So help me God.
Any other?
Affirmation. I, Amadou Rijalo, do hereby affirm that I will speak the truth, the whole truth, nothing but the truth. So help me Allah.
Thank you very much. That is it. So you two are going to speak on behalf of on behalf of your unit. Unless otherwise, yes, no problem. When that otherwise arises, we will also do the same to anybody who wants to take the floor. So thank you very much, Madam Secretary. Now coming to business proper, a communication was sent to the Epidemiology and Disease Control Unit, summoning them to write a position paper with regards to the acute kidney injury among children. And a response was also received on the 8th that they have sent in a position paper outlining some of the interventions they have made and many other facts as far as their unit is concerned. Another communication was also sent to them, summoning them to appear before the committee today at 11 a.m. and here they are appearing before the committee for our usual business. So I will now open the floor and hand over the discussion to them. And I think we are all in receipt of their position paper. Honorable members, I think we are all in receipt of the position paper. Yes. Good. Now we hand over the mics to them to take us through what they have. Not necessarily everything, we read everything, but just summarize some of the most salient points. The rest we will also do at our own and get something out of it. And at the end of the day, whatever that you present here, being it written or oral, we are going to use it and then we are going to mark it as evidence as far as this inquiry is concerned. And if we are done with the inquiry, we are going to write a report that we will present at the floor of the National Assembly with recommendations and resolutions which will be adopted or otherwise deemed to be done anyhow by the plenary, and by then we will also come out with something. But that is the mandate of the plenary. Our responsibility and role as far as we are concerned for now is to do the inquiry and report to plenary. Thank you very much. The floor is yours now.
Good morning, honorable members. It's our pleasure as staff of the Epidemiology and Disease Control to be here to discuss with you on the current situation on the acute kidney injuries. I just want to introduce to some of you to understand what the rules of the Epidemiology and Disease Control is within the Ministry of Health. This is a unit under the Directorate of Health Services that is given the responsibility to intervene or to investigate on every health event that may be of national or international concern to find out what is happening. And it is in the same vein that when the acute kidney injury event started, we were also given the responsibility, we were alerted and then to go ahead. Dr. Anna will go in detail into that. So as the term goes, epidemiology is just the study of diseases and events and their distribution and determinants as to what happens around us. So this is the whole situation. So when it started, we were contacted and then we had to take our steps and go ahead. So I would hand over the mic to Dr. Anna to take us through those steps that are our mandate and our responsibilities in this response aspect. Also, you need to be reminded or make it clear to you that the Epidemiology and Disease Control also has what we call the Public Health Emergency Operations Center. This is a center that is designed to respond to public health emergencies in a coordinated manner. And we use that approach as well during this response. So I would hand over the mic to Anna. Thank you.
Thank you, Amadou. Good morning, everyone, once again, honorable members. I'll give a brief introduction of the definition of AKI. That will give us an idea of what the condition is all about. Then I will go into events as to what actually happened throughout the period. So in definition, acute kidney injury, which is commonly called AKI, it used to be called acute kidney disease. So now the term has been changed to acute kidney injury. So it refers to the abrupt, sudden decrease in the kidney function that happens within a few hours or few days. It depends on the cause or the duration. So depending on the cause, it will take days, weeks, or hours. And there are so many causes or conditions that can cause or lead to acute kidney injury, both acute and chronic conditions. Usually it causes an increase in the inbuilt of waste products in the blood, and then makes it hard for the kidneys to keep the right balance of fluid in the body. Usually the kidneys are the excreting organs in the body. There are also other excreting organs, but usually with the urine, the kidney usually processes the urine after the body has absorbed the water. Then the waste comes out with the urine and then is excreted as with the urine outside. So once there's a decrease in the functions of the kidney capacity to process the waste from our system, due to so many conditions, as I mentioned earlier, that could cause an increase in the an increase in the amount of waste in our system, nitrous, ammonia, or other ions, and then even urine also is a waste processed from the body. So some of the signs and symptoms of acute kidney injury, usually patients, it could happen in adults or children. In this case, we are talking about kids. So it's oliguria or anuria. Both is either absence or decrease in the urine capacity. Then you have edema. Edema is swelling of the body. Could be the legs, could be the face, because there is absorption of water which is not excreted in our body. So the water is retained. Then patients become puffy. Either the face or the eyes are swollen, the feet are swollen, it depends. But also swelling can be caused by some other conditions, not only kidney issues. Then confusion. Due to the issue, either there is so much increase in the nitrous oxide in the system, like potassium, or decrease or increase, it can also lead to confusion. Then nausea. Nausea means having, wanting to vomit, boyer to vomit. Diarrhea, shortness of breath, chest pain, and coma. In some cases, patients go into coma that they don't actually wake up, or that's the end. Some would wake up actually when right interventions are done on time, then they will regain consciousness. So in acute kidney injury, this is not the first time it is happening in the world. Studies have shown that it has happened in so many countries, in so many places, and then globally, it has shown that there is 30 to 50% among, it has happened in 30 to 50% among children. Usually it happens more in those undergoing cardiac surgery. So the rate is usually high among children because one, their immune system is a bit low, two, their body function and capacity is not like the adults. So usually when it happens to children, they usually succumb to it in most instances. So usually it's common in wards, especially in children receiving aminoglycosides. These are drugs actually. And then multiple nephrotoxins. Nephrotoxins are drugs that actually affect the kidney. There are certain drugs, when you take them, especially when you have kidney issues, it actually decreases the function of the kidney. So the kidneys cannot excrete the drug, so actually the function of the kidney actually decreases. So in a study conducted in developed countries, the incidence is between 3.9% out of 100,000 live births and 34.5% out of 100,000 live births admitted in neonatal hospitals. So a similar incident also happened in other countries, as I mentioned earlier. Like Nigeria had an incident of acute kidney injury, Haiti also had and also a similar incident, especially in children. So that's the brief introduction of the whole concept of acute kidney injury. Then we go to the sequence of events. So we were notified as an office, as Amadou mentioned earlier. EDC is the office or the body responsible for investigating outbreaks, conditions within the Ministry of Health. So we were notified on the 26th of July 2022 from the Director of Health Services that there's a sudden increase of cases of deaths in the pediatrics department, which needs to be investigated. It was sudden, it was abnormal, because within that short period, there were so many cases of deaths that they don't know what is the cause, that we need to go and find out what could possibly the cause. So the age range that was given to us was between 2 months and 7 years at the pediatric emergency unit at EFSTH. That was the only place that was actually initially reported to us. So upon receiving notification, our office dispatched a team to EFSTH to confirm the existence of the event. In every outbreak, once we are notified that there's an outbreak, we need to go and confirm if it is true or if it's not true, or if it's just a rumor that actually the outbreak is occurring. So what we did initially as a plan was, we convened a meeting on the 27th of July, the following day, based on the information gathered from the team that went to do the initial investigation. So a stakeholder mapping was conducted to identify all the key actors whose contribution will be needed during the investigation. A rapid response team was instituted, led by the acting program coordinator of EDC, to visit the pediatric consultant and also the ward, and also the management of EFSTH, just to gather additional information on the event. Because when you want to investigate a disease or an event, you need to gather additional information. So which was actually shared with the Director of Health Services and other stakeholders, which triggered a subsequent response activities. So the next step we did was we activated the Public Health Emergency Operations Center. So the Public Health Emergency Operations Center is housed at Kotu at the EDC. So it's the same staff of EDC who are managing the Public Health Operations Center. We are the ones who manage, investigate outbreaks, conduct surveillance, and all those things. So it was activated through the Director of Health Services, because EDC is under the Director of Health Services. And then the IMS, which is the Incident Management System, was instituted to coordinate the investigation and response activities led by the incident manager. So we had an initial incident action plan. In every outbreak, you must have an incident action plan. So it was developed and implemented to guide the investigation and response. So the IAP was updated regularly as events unfolded, depending on the cause and the additional information we get in the field. Usually the IAP is updated. So in order to facilitate the active case site in the health facilities and communities, we also created an outbreak case definition, which was developed and shared with the regional directors, chief executive officers of hospitals on the 2nd of August. For every disease condition has its own case definition. A case definition differentiates every disease condition from another disease condition. So based on the symptoms, we are able to differentiate if, example, this is malaria and this is not malaria, because every disease condition has its own description. So the next step was we formed an investigation team. So the initial outbreak investigation team comprised of the EDC staff. We are all here. And then we also included the National Public Health Lab staff, because we are not sure what it was, so we need to confirm, collect samples, and then we needed the lab to help us with the results, because they will do the testing. Then we also include the RHDs. Those are the regional health directorates, because we have 7, and then every hospital is within an RHD. So you cannot go ahead without involving the RHD, because sometimes they also oversee every facility within their region, and then they support in the capacity and also in investigation of cases. We also included WHO, who were actually with us from the onset. They did help assist in finding out also what could be or the probable cause of the event. AFINET, which is the African Field Epidemiology Network, was also part of it. We have an RA, a representative there in the office, who supported in the investigation. And then most of us here, we are all field epidemiologists, we are all trained and members of AFINET, kind of. So MCA was also on board. Water quality lab was involved. The main reason why we involved water quality lab, because we weren't sure what was the cause. So we had to include them. And then PIRA were also involved. The US Embassy CDC were also called upon to assist us. As I said initially, we didn't know what we were dealing with. So looking at the investigations, the team visited and interviewed staff of the pediatric unit of EFSTH, because that was where we got notification first from. Then we also visited Kanifing Hospital, Brikama District Hospital, Bansang General Hospital. So all the major hospitals in the Gambia were visited, because most of the cases that were referred to EFSTH did present in one of the above mentioned facilities before they were referred to the EFSTH. So we also interviewed, the team also interviewed caregivers, mothers, and then parents of the cases, just to obtain the demographic information, date of onset of illnesses, what was done before they presented at the hospital, what were the signs and symptoms, travel history if possible, medications given before they actually visit any facility. Some did conduct home medication, so we wanted to find out what could be the possible cause. Even herbal ingestion, we did ask for herbal ingestion, chemical exposure. So a record review also conducted, and patient folders were also reviewed at all hospitals. So EFSTH, Bansang, Brikama, and Kanifing. We also included this time around Sukutaf and then Fajikunda Health Center, just to search for additional cases using the case definition as I mentioned earlier. So our key findings, we had a descriptive analysis of the cases, then which was supported by literature review, and then we came up with recommendations, and then at some point you were able to identify some challenges we faced in investigating the outbreaks. Then we conducted daily coordination meetings to share our findings and also to inform the stakeholders of any recent information we got that was never shared or that was never obtained. And then also we collected samples from the cases and even non-cases, just to know what we are dealing with. We took medicines from the cases, food, blood, urine, and stools. And then we were able to send some to the national laboratory like NPHL in Kotu. Then some were sent outside the Gambia because we didn't have the testing capacity to test those samples. So they were sent outside the Gambia. So our key findings were from the 4th of June to the 6th of November 2022, a total of 8 suspected cases, 2 probable cases, 82 confirmed cases, and 70 deaths of AKI were reported in the country. So with the 70 deaths, once we calculated the case fatality rate, we had 85% case fatality rate. Yes, case fatality rate.
Madam, before you proceed,
Yeah.
I know it will interest the members to know what do you mean by, let's say, a total of 8 suspected cases, probable cases, and probable cases, yes,
Okay.
and confirmed cases.
Okay.
Don't worry, it's a fly English.
No worries. I did mention earlier that we had a case definition, and every disease has its own case definition. So the case definition differentiates every particular disease, like malaria from AKI or malaria from UTI, because there are some classical symptoms that one will have that will be like, okay, this, I think it is malaria, example, or this is actually meningitis. So in the case definition, we also have categories underneath it. We have suspected, confirmed, and then probable, and then confirmed. That's the three title category of a case definition. So under suspected is once the case presents certain characteristics or signs and symptoms that you think it's actually a particular, like it's AKI, but it's yet to be tested. So probable is like a suspected case without any confirmation. Maybe the person died. You suspect that it's AKI, but the person died without any testing. So we are without confirming, without testing, to get the confirmation that it is actually AKI. So that's a probable case. It's beyond suspected. For suspected, they are all alive, but they have to be tested. So, and then for a confirmed case is one who has all the parameters. One, signs and symptoms are present, and then supported by the lab investigation. We have particular parameters. Once you test, once you do the test, like the blood sample, to test for kidney function, that will tell you actually that this person has AKI, because some parameters will go up, like blood sodium, potassium, urea, creatinine will all go up, will all shoot up to show that this person has some kidney condition. Like I said, any other disease also, once you do the particular test, it will tell you actually this is a case for a particular disease or not. Is that okay? Yeah. So case fatality is like the number of cases that have died due to a particular condition. So it's calculated like it's like a ratio sort of. We calculate it based on number of cases seen and then deaths times 100%. Yeah. Majority in continuation. Majority of the confirmed cases were males. 50 out of the 82 were males, and then children who had 3 years of age were 68. So out of 82 cases, 68 were below 3 years. So we've also realized through our analysis that Western One region recorded the highest number of cases seen. That was 35 out of the 82 cases seen of the confirmed cases, followed by Western 2, which was 23. The outbreak has been ongoing for 5 months from June to all the way to October, July, August, September, October. Findings from the analysis of the syrups also indicated that promethazine oral solution, BP, Cofex Malin, which is the baby syrup, cough syrup, Macof baby cough syrup, Magrip and cold syrup were contaminated with diethylene and ethylene glycol. So in addition, 57 stool samples were collected from the public facilities within Western One Health region from patients who were present with acute watery diarrhea and any other symptom of. So in this situation, we had issues. Cases which had acute kidney injury were not making urine because that was a problem, and we are not making stools also. So it was difficult to test. If you don't have samples, you cannot test. So we wanted to have an idea what is happening in the public. So what we did, we went to public facilities at the OPDs, collected stool samples from all the kids who presented at the OPD, just have an idea what was actually happening. So that was how we came about with collecting 57 samples of stools from the public facility. But they were not AKI cases, actually. But after testing also those cases, we've realized that because samples were collected and then sent to Dakar, because we had some issues with the lab, sent to Dakar for confirmation. So the outcome of the samples were 9 were negative out of the 57, and 38 had E. coli. Escherichia coli is a bacteria in our, it can be found in water, in stools. Yeah. So it was found. And then with E. coli too, there are different types. So they were typed into their categories. We have some that are toxic to our system, some they are okay because it's part of our normal flora. Even in our body, there are bacteria, which is okay because they are not harmful to us. So when we did the typing of the different types of E. coli found in the 38 stool samples, the type called E. coli 0157, we isolated 2 from those 2 samples. Then the enteroaggressive E. coli, we had 6 from that. Then the enteroinvasive E. coli, we had also 6. Enteropathogenic type, we had 7, and enterotoxigenic type, we had 17. So we also took first stool samples, and then did typing also, and then we found Escherichia E. coli phagosini from those samples. So the typing, for this one, the typing was done in MRC. So serum, urine, and whole blood samples from 5 AKI cases were also collected and sent to Dakar for toxicology analysis. But the findings showed that all serum samples found positive levels of paracetamol, but they couldn't quantify because they didn't have the mechanism to quantify the amount of paracetamol found in the samples. So that was initially because it was a challenge to collect urine and stool, so we were able to collect blood samples from those cases. We also went around communities and then collected water samples. As I mentioned earlier, we didn't know what we were dealing with. So we were able to collect 7 water samples from the households of the cases, just to ascertain whether was the water toxic or was it infected. And then also tested the fecal E. coli. As I mentioned earlier, there are different types of E. coli, but in this case, the fecal type was found inside the water samples of those homes. And yeah, in the feces, actually. And they had different sources of water. Some had tap water, some had borehole, some had well, actually. So it was not the same source of water, actually. But however, we are still conducting routine surveillance just to monitor the situation, and then also continue the investigation, because we've not concluded that this is the possible, this is the confirmed cause of the AKI. Could be virus or anything. We are still trying to test and see, and then further investigate to see what we would find out later on in the future. So our key interventions and actions taken, with regards to coordination, we usually conduct a daily coordination meeting at 3 p.m. at the PHEOC, which is chaired by either the Director of Health Services or the Incident Manager. And usually feedbacks are conducted every week, which is chaired by the Minister, Honorable Minister, or the WHO representative in the country. So key response pillars for the establishment of IMS for the response to the AKI gives update daily, which is done daily during the 3 o'clock meeting. Actually, on the last page, there is a diagram that showed our IMS structure. That's the last diagram. So the incident management structure. So it will tell us the key pillars that are involved in the response. So with regards to the epidemiology and surveillance, we developed a standard case definition, which is reviewed and then updated as we move on. Because sometimes when you go, we realize that there are other symptoms, cases present in another way. So it's updated regularly, actually. And then with regards to even the management of cases too. So we also developed an AKI case-based form, which is currently being used to investigate cases, and then which usually helps also to update our line list. So that every case, confirmed case of AKI, has its own case-based form. The form is very detailed, has the demographics, patient history, history of disease, then tests or tests conducted, and then the outcome of every investigation done for the cases. The surveillance team prepares the CTREP or the situation report, and then develop a one-page infographic situation report, which is shared with the public. Our CTREP is shared weekly. Every Friday is shared for that people would know what is actually happening. If there is any additional information, is shared, and then just to update the stakeholders as to what is really happening. Where do we have new cases, what more investigation have been done, and any other issue.
What do you mean by this? Is it CTREP? And how is it shared? Is it shared among you people, or is it shared out to the public?
It's shared with the stakeholders and then the IMS team. But we also have another template which is shared with the public. Usually it's coordinated by health promotion. It's just that not every information can be shared with the public. A community-based case control study is underway. Currently, the protocol is being developed. So we did conduct a hospital-based case control study, and then the case control studies will help us ascertain what could be possible risk factors that some kids are developing AKI and some kids are not developing AKI. They could present with similar symptoms, similar exposures, but we realized that some would have AKI and die, and some wouldn't even develop AKI. So the case control study will actually guide us as to what could be the possible risk factors. Maybe there are other risk factors that we don't know that the study will actually tell us. So we've developed the protocol, and then we're working on conducting the study in the community. Case management or clinicians train on how to fill the AKI case-based form. As I mentioned earlier, we have a special case-based form for acute kidney injury, which was developed during the period of the outbreak. So we've trained clinicians, those in the hospital, and then we're going further to train also surveillance officers or the public health officers who also understand how to fill the case-based forms. Efforts are also ongoing to strengthen community-based detection and reporting. Not everybody reports to the hospital. Some cases don't reach the hospital. So what we want to do, and then some cases might be missed if we depend on hospital data. So sometimes it's also good to go to the community, inform them the situation, and also engage them as to what AKI is all about. Some would go to traditional treatment centers or herbalists, and they wouldn't reach the hospital. And sometimes some would go to a health facility, you refer them. Due to so many conditions, they wouldn't reach where they are referred to. They either go home and then seek additional treatment or somewhere else. So in regards to the community engagement, we've realized that like two cases actually were not reported in our hospital data because they died at home. With regards to the medicines and pharmacology, a recall exercise of the contaminated syrups from the communities were carried out in the health regions of the Gambia. So it was supported by Red Cross, WHO, Child Fund. So we've conducted a nationwide drug recall exercise in all the regions in the Gambia. We initially started with the first 3 regions that had most of the cases. That was Western 1, 2, and URR. Then the second phase, we included all the other regions across the country. Causality assessment and risk-based survey are currently being conducted. This is led by MCA, just to ascertain if actually AKI was caused by the drugs that were tested or confirmed to have, e.g., that's diethyl glycol and ethylene glycol. So they are currently conducting a causality assessment to ascertain if the cause. So with regards to risk communication and community engagement, media briefings, radio, TV talk show, and panel discussions with engagement of stakeholders, community are being conducted. Press releases were issued on the incidence of the AKI, suspension of quarantine of drugs, and the possible linkages of drugs to cases. They've already been done and then shared. Risk communication and community engagement team with Red Cross Society developed a video showing contaminated medicines. In this video, community members were requested to stop using all medications produced by medium pharmaceuticals or take them to the nearest health facility. In conclusion, a total of 82 cases of acute kidney injury were recorded with 85% case fatality rate. The majority were males and then were less than 3 years old. Western 1 and Western 2 were the highest recorded regions in the country. The emergency has been ongoing for the past 5 months from October 5th to date to confirm cases of AKI has been identified or reported in the country, and investigations are still ongoing. There have been challenges that warranted the posting of public health officers to 2 busy hospitals, that's EFSTH and then Carnifin General Hospital. Initially, they didn't have surveillance officers or public health officers there at the hospital. So when we started reporting cases, we realized that they needed surveillance officers in those 2 facilities. So they were posted recently there. A few of our challenges includes incomplete information of case patients and remains a major concern, and refusal of families to respond to the interviews. We understand their situation. They are still mourning and grieving. So it's difficult to get more information from those families, especially the caregivers, because sometimes the information they give us at the hospital is incomplete, and then we want more information. You call them to go to for the address or to visit them. The response sometimes is not nice, and sometimes they don't want to see you at all, and the blame is on you that you're not helping or you've done something. So it's difficult. So sometimes we have forms that are still having missing information, and it's difficult to proceed and make your analysis based on the incomplete information. Recall bias by family members during interviews. We can't blame them. Sometimes they forget. And you have to probe and probe and probe. And some don't want to tell you that we've given this medication or we've done this to the kids before they visit the hospitals. And it's normal, because in our society, when kids are sick, sometimes you'll be like, let me observe at home for a few days before we go to the hospital. Or let's start some medications at home.
No,
So
Doctor, what do you mean by recall bias?
Forgetting to, like, so when you ask certain questions, they either forget or they don't tell you or they don't respond. So sometimes, like example, if you give your kid a medication or a drug for the past 2 weeks, and you ask, was the child sick for the past few days? They will like, no, the child wasn't sick. You have to probe further and ask, or maybe you can go like a month ago, was the child sick? Did you give any medication? And how much you give? So that even if they tell they gave medications, they can't tell you how many doses they give, which is also important. Yeah. Lack of in-country lab to conduct toxicology tests. That's one of our challenges. Not only toxicology, but even other tests. One, it delayed our response on the investigation, because the first 5 samples that we had sent to Dakar for toxicology, and then they found a paracetamol, it took over 1 month before we got the results. It really delayed us. Then we had to identify another lab that was sent to Ghana and then Switzerland. But if we had a lab in the Gambia, it wouldn't take that long. Yeah. And apart from even testing of drugs, even our normal NPHL lab, there are other things they don't have, which is actually affecting our work. The typing, I did mention that we sent 57 stool samples to Dakar for typing. They didn't have the reagents, they didn't have the materials to work with. That was why the samples were sent to Dakar for typing. If they had it, we wouldn't have delayed our response and then getting answers to what we are actually dealing with. In as much as we have the skills, but the capacity is not there. Inadequate or lack of psychosocial support for healthcare workers and the affected families. Managing these cases was difficult. I'm a clinician. I used to work in the hospital, so I know what is it like to record deaths every day. So you managing cases and seeing that by tomorrow this child is going to die, it's difficult. So when I go to the hospital every day to review, to get data, me talking to the mother, knowing that tomorrow morning if I come here, I will not see the case, it's a difficult situation. So much more the clinicians who were actually with them all throughout the period. I can pop in and go in the morning or in the evening and go out. But for them who were there all throughout, it's a difficult situation. I've been in the pediatrics department, but something like this never happened. Yeah. In as much as when you work in the hospital, that is, I would say, something like normal, but not in this kind of situation. So, and then also with the affected families, they need psychosocial support. And then we have few people, not so many, but at least that can also cover. But it's actually a difficult situation. So some of our recommendations are, we continue the daily coordination meeting at the PHEOC, which is done daily at 3 p.m. continue the active case search and sending surveillance at the communities and then the health facilities. We are still conducting active case search. Few clinicians were trained, and also we are moving forward to train surveillance officers and community health workers who assist us in conducting active case search, because we've shared the case definition, and then the case definition would guide them as to what they are actually looking for in the communities. And then once we involve and engage the community members, when they have suspected cases, they will report to the village health workers or the community health workers or to the nearest health facility that they have suspected cases. Conduct further studies to establish causality assessment of AKI in the country, which will be done, and then extend the psychosocial support to affected families. Strengthening feedback mechanisms to all stakeholders. Strengthening risk communication and community engagement. It's currently being done with the help of health promotion, though it's a component in the IMS structure. Then the Gambian government to partner with and partners should provide a toxicology lab in country that will help us to test for our drugs, medications, and not only toxicology lab, to strengthen our national public health lab also. And we also have issues with mobility, especially vehicles, in responding. It's not there, but in responding to emergencies, it's actually a challenge. Currently, our vehicles are seized or impounded, and it's difficult in such a situation. So we don't have vehicles in the office to go and investigate.
Can you please shed light on that? Currently, your vehicles are seized and impounded?
Yes, at Riders, and also at Denton Bridge. So we don't have. In a situation like this, I think we should be exempted. At least they know it's an emergency. It would not be nice. Example, if I have an AKI case at home, how would I feel? So that's our situation now. I think EDC should, in the situation of emergency, should be exempted from such a situation. In page 8, we have the diagram of the timeline that I've just explained. And then the last is a summary of the IMS structure that we've created due to the response. I thank you all for your kind attention.
Thank you. Thank you very much, Madam. But one interesting thing, before we even go to the proper discussion proper, about the issue of mobility. You said currently your vehicles are seized and impounded. You mentioned Riders for Health, right? And is it at Denton Bridge? Can you please shed more light on this?
Yes, what happens is 2 of the other vehicles are being managed by the Riders for Health, and they are impounded. That they should not move now. I think for all the Riders for Health vehicles under the Ministry of Health are parked at the moment. And EDC was part of it. So when my driver told me, I called at the Riders for Health appealing for at least one of those vehicles to be allowed, which is within the response. But what he told me was, at this point, it's beyond him. He cannot do anything. I called the Director of Health Services. I told him, informed the Permanent Secretary, and I wrote to them. And I'm waiting for a response. So that's it. So the other one, it was Monday? Yeah, Monday morning. The driver was going to get fuel, and he was impounded by the securities that they need the vehicle for the presidential tour, and the vehicle is taken away. So the driver is at the office waiting.
Wow, that's fortunate. Okay, thank you very much. It was important we clarified that aspect. Honorable members, subject matter specialists, and technical staffs, we've all had the submission made by the Epidemiology and Disease Control Unit under the Ministry of Health. They have explained from the onset what they have done, the investigations that they have been doing, and how they have been involved, and also come out with possible the challenges that they face with, and also possible recommendations. So we thank you very much for honoring our invitation and also honoring the communication we sent to you to send in a position paper. This it's a welcome move, and it will definitely help us in preparing our report to the plenary. I can assure you that all that you've submitted here will be reviewed by the committee in our all internal meetings, and then we will take whatever that we need to take out of it and add it to our report. It is incumbent upon us to request for witnesses to appear before the committee and also take evidence from you, but it's also our responsibility to also ignore evidences that are given to the committee. So it is a two-way thing, but I know for certain any evidence that is given in this course which is valuable and then which we can definitely substantiate at the plenary, we will take it and put it as part of our report. And this is one of it, because it seems like this unit has been involved since day one. You have been in this process all along. In fact, you know most of the issues that have happened here, because just to confirm some of the revelations that you've made here yesterday, the National Public Health Laboratory were here, and your submission is similar to that of them with regards to the lab investigation. So in essence, there is a confirmation of information from the National Public Health Laboratory and that of the Epidemiology and Disease Control Unit with regards to the lab investigations and so on. So thank you very much. I will now open the floor for honorable members. If you have questions, contributions, comments to make in this regard, you are welcome. But first of all, Doctor, there is this question that I want to ask. There was a communication sent in by WHO that was in all media, even international media, saying there are contaminated medicines found, and they are found in the Gambia, and they are linked. Are they linked to the AKI? Or if they are not linked, because already the pronouncement was made at the level of the WHO. So it's a bit like two-step thing from the Ministry of Health and that of the WHO. Because if you read the press release from the WHO, for sure, you will definitely know that there is a high linkage between the AKI cases and that of this, but not confirmed, as you said, because you have to do some, how do you call it, causality test or so on. But we just want your opinion on that.
As I mentioned earlier, we didn't know what we were dealing with. So we took samples everywhere, from blood, urine, then medicines, and stools. Based on our findings, we've realized that most of the cases that had AKI took the medications. One, based on the presenting symptoms, they had fever, vomiting, cough, diarrhea. And then usually fever, when children have fever, they're usually given paracetamol syrup. And then promethazine to stop the vomiting. So when we tested the medications, and then some had cough, fever, paracetamol was initially, when it was tested in Ghana, it was positive, but the sample, they couldn't quantify the amount. So, and then they didn't have the capacity. But the same sample was also sent to Switzerland, and they said it was negative. But with regards to the promethazine, it tested both positive in Ghana and in Switzerland. And then we've realized that if a child doesn't vomit, you wouldn't give promethazine. So that showed that, because we took all those samples from caregivers. It wasn't bought from pharmacists. So that was because we took what they used actually to confirm our test. Yes.
So thank you very much, honorable members. If anyone have anything to say, honorable Young, you use the mic, please. Yeah, but we need use the mic for those guys.
Oh, thank you very much. In your deliberation, you did say that you are not yet ascertaining the cause of this acute kidney injury. And you did say the terminology just changed. It was called acute kidney diseases. That being the case, I think you should know the cause of it. since the terminology is the only thing that changes?
I mean, initially, in those days, it was called acute kidney disease. But now, it has been changed to acute kidney, not based on our context, but internationally. Initially, you can have acute kidney disease and then chronic kidney disease based on different conditions or cause. So if I understand what you said, can you please repeat what you said?
What I mean is, since we know the cause of malaria is mosquitoes.
Yes.
I think-
Plasmodium.
Yes. And we should also know the cause of this disease, since it was in existence before.
Yes, but acute kidney injury, I did say, has many causes. Shock can be a cause. Infection like sepsis, bacterial infection can be a cause. Dehydration can be a cause. Cryogenic shock can be a cause. There's so many causes. So in this case, we are not too sure, because we are still dealing with a condition in which cases present with fever, vomiting, diarrhea. Anybody who presents with fever, there is a underlying infection. That is why cases present with fever. If you don't have any infection, we wouldn't have fever. So in this case, in as much as we've confirmed some medications to be involved in it, but we still need to find out what is the cause of the fever and what is causing kids to, caregivers to start self-medication at home prior to visiting the hospital. Because there's a period in which when these cases get fever, vomiting, they self-medicate 2-3 days before they develop this AKI. What is the leading cause of that fever, vomiting? It's very abnormal for people to get sick. So we need to find out first what could be the cause. Could be virus, could be bacteria, could be something else before they develop the AKI. Yeah. Yeah.
The substances that you've mentioned here, that we are present in these syrups, that is the...
PG and diethylene.
Yes, diethylene glycol and ethylene glycol. Can they cause acute kidney injury?
Yes, they can.
Okay, thank you. You can also clarify.
Okay, thank you very much. I just want to set you back, just to remind you, and I will start with what she mentioned, case fatality rate, which was at around 80 something. I may not be sure right now, 85%. This means if you have 100 cases, because of the situation under which we were going, all 85 will die. And that is a cause for alarm. And let me just tell you, when this thing started, at some point, we were even expecting 100% case fatality rate. We were expecting. Why? Because the first day we went to the hospital, when we were informed, already 6 children has already died. And we had 3 within the ward, and I would fully remember that the nephrologist told me these 3 kids are also waiting to die. So imagine how serious that is. So we were so worried that we cannot just jump to a conclusion and say this is responsible. So we started reading about publications, what has happened around the world. We realized that that terminology you're talking about, acute kidney injuries, has happened somewhere in the world. And in some instances, it was related to some medicines, and as she said, some could be due to microorganisms, due to bacteria or whatever. So now we didn't know which one. So we have to start our investigations. She also mentioned about a case-based form. This is a form which you register cases and get certain variables, like their name, their age, their gender, their addresses, even the type of food they take, the type of medicines they have taken, and so on. The signs and symptoms they have presented, because that will tell us a lot. So we use this to determine what could guide us as to what we may think about. So at that point in time, we can never say this is responsible. So we started investigating. And this is why at the beginning, it was only the EDC that has started the investigation. So we started bringing in people You realize that we brought in water resources for them to help us for the water samples that we are going to collect so that they will test them. We involved the national public health laboratories. We cannot conduct surveillance without the lab because we need to test and confirm whatever samples we are going to collect. And then whoever we think is relevant in this response, we invited them gradually. And internationally, even the partners, we started bringing them on board. We started with WHO, but later we brought in the Africa Field Epidemiology Network, who is already somebody who is already within our office, working with us. We also involved the PURA, that is Public Utilities and Regulatory Authorities. So you would see how diverse we started thinking. When we thought of medicines, we said, no, we cannot deal with medicines without the Medicines Control Agency. This is why we brought them up. We even went to a point that we invited the Department of Livestock Services because we know there are certain diseases that can be obtained from animals to humans. So we wanted to make sure we clear all the doubts. So this is the approach we were taking to make sure everybody is involved. And this is how it was moving gradually.
Thank you.
Sorry.
A supplementary?
Yes, supplementary.
Yes.
It's a different question.
Yeah, please use the mic.
Okay, thank you. You stated some syrups here. My question would be, is all these syrups from the Maiden pharmaceutical pharmacy?
Yes, they are from the same pharmaceutical company.
Oh.
That have EG and DEG.
Yeah, confirmed ones.
Okay.
Thank you.
Thank you. Yes, honorable members. Honorable. Sorry, honorable. I think you asked the floor before him. Yes, you can come in. GB, you can wait.
Assalamu alaikum. Madam, for me, I'm a little bit confused here because you mentioned water, and initially we are talking of the syrups. So when you mention water, I have a doubt on that.
Actually, as Amadou mentioned earlier, we didn't know what we were dealing with. So we were taking samples, what they could have been exposed to. So we took their blood, urine, stools. That wasn't enough. So we were like, possibly, we couldn't conclude like this is the cause. Then we were like, we visited their homes, took water samples, because at least maybe water was contaminated and it was during the rains, possibly. Maybe it's cholera, we didn't know, or could it any other infectious disease. So that was one of the reasons why we collected their water samples. As we know that water, there are some infections that actually are waterborne that can cause diseases. Because patients presenting with fever, vomiting, and diarrhea, especially vomiting and diarrhea during the rain season, is more of fecal oral or something they eat, kind of. So we aren't sure. And if we had the opportunity even to test their food, we would have done that. But we didn't have the capacity to do that. So that was why we took their water samples, actually. Thank you.
Thank you very much. Honorable, are you okay? Yeah. And then, in fact, on top of that, doctor, yeah. We all understand, and for the past years, we were experiencing some floodings, and then even some unfortunate instances as the possible causes of AKI. But the interesting thing is, such an incident of this magnitude have never happened. So what the common man will say in the street is, he will just go into a straight conclusion. I know, as health experts, as health authorities, and also scientists, you cannot just jump into conclusion. Mm-hmm. But the common say in the public, they will say, well, this thing has been happening so and so, and then we have been experiencing this. But this unfortunate thing also happened on top of this. They will directly relate it to it. I know we cannot do that as responsible people. And then as a National Assembly committee, we will never be a party to that unless and until we have all the proofs. But what do you have to say to that? Because I know people are listening and they are following.
This is why I said we didn't know what we were dealing with. So, and then the timing was also during the rainy season. That was why we went further to collect. Usually we wouldn't collect water samples if we knew the cause from the onset. So collecting water samples would actually tell us scientifically whether is it actually there's a causative agent or not. But we cannot conclude that to say that it's because of the rainy season. I wouldn't support that. To say that because of the rainy season, the water levels have gone up, that is why people develop AKI. Then we would have also had cases of cholera too, because it was also during the rainy season, and then cholera is waterborne. Well, we didn't have any case of cholera. Yeah.
Thank you. Yes, Honorable Mbalo.
Yeah, thank you very much. Mention about the caseload, like in terms of region, we can have that. That would be very good for this thing.
Okay.
And then the question I want to ask: are you people afraid to tell the Gambian people the reality? Why I'm saying this thing? We are saying that from your presentation, it's either bacteria, medication, or toxin. You have made an investigation on bacteria. Is the bacteria present? You have made investigation about the medicine. Is the medicine thing? If these two are the things that are linking to this thing, I think at your unit, come and tell the Gambian people. But if we continue saying that we are certain bacteria, medicine, and the results for your tests reveal that bacteria is found, and your results on medication found out that something is found contaminated and that could lead to this, I think we have a standpoint to say. But if we are still further remaining to say, to me, I feel something that we are hiding away from. At our context, not scientifically, but looking at the investigation that have done, reveal that something, we can proudly say this is the cost, if I may right. And then, but if we continue telling the nation that unfortunately scientific, and what is happening in our own domain that we see, because one of the victim informed this assembly that the child was sick and was taken to a previous clinic. Upon arrival, a lab investigation was done and he said he had severe malaria. The table told around that he was, after taking the medicine, he was later having complication that was diagnosed as acute kidney injury. Admitted, undergo surgery, and end up dying. But the guys there, or you people, can tell Gambian that that one had malaria. And then the test result have shown something. To me, I definitely want you people to tell us if bacteria is seen as a causative and is seen in all these patients. If medication is found, then that can give us a way to go. Thank you very much.
Thank you, Honorable. I did mention that we collected 57 samples, but I also said that they are not AKI cases. So the 57 samples are not AKI cases. That was just something to guide us, because the AKI cases were not making urine or passing stools, and it's difficult. So if you're not making urine or passing stools, and then we have this lab that is still in Dakar, not showing any results, and we can't also sit and fold our hands, what do? We went around the hospitals and then just take samples from all the kids who came to the OPD, just to have an idea with what diarrhea, vomiting, just have an idea what is happening in the community. That was what led us to knowing that there was E. coli in the system. And also with regards, but I also did say that there are risk factors. Others will take medication, nothing will happen. Others will take medications and something else will happen. And then depending on what else they are exposed to, and then the dose they were also exposed to, also it's also important. So this is why I said we can't conclude. If the bacteria, as for the bacteria, all the E. coli cases didn't have AKI. And then with regards to the medicines too, because even the question we also ask, some are not actually in Banjo, or even in Banjo, but in other wards, but they'll still take medications and then they'll be fine. But what could be the possible risk factors? Some are susceptible, depending on our immunity and then our genotype or our making. Some are stronger, some are weak. So we cannot conclude to say that actually this is the cause. But what could be, what is the cause of the fever vomiting before they came to the hospital? We need to find out. Could be a virus, who knows, or even COVID, but we don't know.
Supplementary?
My question.
Okay.
The issue is the lab people came here.
Yeah.
And they told us that they conducted tests. And these are tests of people that were found with AKI and died even. And they told us from them bacteria was identified. Confirmation of which kind of bacteria was later sent to Senegal, and they say E. coli.
Yeah.
So they're telling us here that those patients, that the samples were collected, they were not able to have some of them urine, but stool, but they told us here that the investigators showed that there is E. coli bacteria found. So, and those people were cases of AKI, and they even died. I think there are records here. That's what they told us. And I believe you people should be aware of this. The linkage I'm doing here is, I'm linking the bacteria causative part of it and the medicine-related part of it, because we commonly understand that there is a pharmaceutical malpractice that have occurred in median pharmaceutical. No medicine should be contaminated. And it have found it have been contaminated. But let's look at the two. If the results of the lab are telling National Assembly where E. coli is there, and then doctor is present to tell us one of the causative things could be related to bacteria, I am linking that bacteria aspect of it. But if doctor is also telling medicine is contaminated, and a medicine is found to be contaminated, I am proving that what doctor is doing is that. Now those two, doctor, be proud or be happy enough to tell Gambians or the EPI that both medicine and bacteria have caused this thing. EDC. Both the bacteria and because if we continue like this, for us representative of people, they are telling us that you people want to hide, but we all common know that the medicine killed our kids. That's what they are telling us. So, and then, what? Sorry, okay, thank you.
Doctor.
So, like what you said, both bacteria and medications can cause AKI. And I agree with you. I did mention that there are different causes of AKI, and then bacteria can cause it, causing sepsis, and then drugs toxicity can also cause it. Thank you.
Thank you. Yes, yes. You have acting director. You have something to add on to that?
No, what I just wanted to add is, at our level, our responsibility is to conduct observations, to investigate what is happening. And we have been monitoring the situation from day one up to today as we sit here right now. We are monitoring the situation. But we can also tell you, we have an observation that from the time we stopped people from using these medications and we conducted the household recall, we have not got any confirmed case or death of AKI up to today.
Interesting.
This we can tell you. But to just jump to conclusion and say, yes, is this or that, we need to conduct researches which is ongoing to ascertain that. We know this is a very critical situation. You cannot tell people A, and then the next day you come and say, no, it's not A, it's B. But we can show what we have observed, and that is the situation as we speak right now. And we are happy with what we are observing. Thank you.
Okay, when was the last case reported?
On the 5th of October.
Okay, it means something must have been done before the 5th of October to now, by the 5th of October to now, until cases are not seen now. Can you share with the committee what has been done?
What we did was we conducted household recall exercise that was done nationwide. So we started with the first 3 regions that reported cases. That was Western 1, 2, and URR. Then we moved to the other regions. And also we did massive community engagement, radio talk shows, and then also public engagement actually. Press briefings, and then with the help of Red Cross also, we went to the communities to involve community leaders also with regards to AKI. So that really helped. And then we've conducted and still conducting trainings amongst healthcare workers, especially the clinicians. And then we are going further to conduct also surveillance, to train surveillance officers also on AKI.
Thank you. That's helpful. That was definitely helpful. So, you want to add something?
Yes. So some of these activities also, like they are not done by EDC alone. We are coordinating most of the response. So we work with like responsible people. If it has to do with sensitization, we work with the Health Promotion Directorate. If it has to do with this medicines recall and even the samples that we have collected, sending for testing, for that we had to do it with the Medicines Control Agency, the National Public Health Laboratory, and the WHO jointly. So those are the observations. And we also worked with MCA. We are working with them closely. So any activity they are doing, we are put in the picture and we participate. At least somebody from the EDC has to work with them. Like as we speak now, they're working on this causality assessment, which we are represented. And also when they were recalling all these medicines or whatever activity they are doing on medicines regarding AKI, the EDC is a part of the issue. Thank you.
Yes, Honorable, could I show your hand, or you are withdrawing? Okay, then you can carry on.
I'm not withdrawing.
Okay.
Thank you so much, my sister. And thank you, EDC. I'm so happy with the work you are doing. So impressed. And what makes me disappointed is that people collecting the vehicles that belongs to you people is not easy while you are doing your work. This work is too hectic. So mobility is very important on the job you are doing. But as a science student, I know that every living human being have bacteria in your body, either harmful or harmless. We have bacteria in our system. But I can take an example from me, like I am a mother, have my own baby with me who is sick, just high temperature, not vomiting. Take the baby to the hospital, that I need medicine. They give me the syrup. When I come back at home, the baby just urinate without taking the syrup. Upon giving the syrup to the baby could not urinate, develop another pain, more painful than before. Take him back to the hospital, and they tell me that your baby developed something which I never know. Most of the Gambians don't know something, acute kidney infection. Most of the Gambian women, most of our parents don't know nothing about this acute kidney. We are just hearing it here. Even if you happen to other countries, we hear it in TV and other places, but in the Gambia, we don't know, we are just seeing this. So, when I see something like that, who am I going to blame, or what will I say? The water my daughter is drinking at home, or the syrup? Because I can say my baby was sick and have been drinking water which I have at home. Take her to the hospital, she have been urinating well, they give me the syrup. After using that syrup, she cannot urinate. Take her back to the hospital, they tell me that she developed something like acute kidney infection. Will I talk about bacteria or water or the syrup as a parent? Obviously, I would say it's the drug I give to my baby. Thank you.
Yeah, thank you very much. I think you made more of a comment than a question. Yeah, so thank you very much. You are heard, Honorable Sisi.
Thank you so much, Chair. I don't have a question. I think I have only one thing I just wanted to relate between the EDC. We have the National Laboratory, Public Health Laboratory. What is your relationship in working towards identifying the cause of this particular case we're talking about, the AKI? Because they were here, you both work at the health ministry. What is the relationship? Are you working in separation, or you working together to identify this case?
Tom. One.
Okay. Yes. Thank you very much. Thank you very much. The National Public Health Laboratories and the Epidemiology and Disease Control Unit are working closely together. We cannot get our work successfully done without their involvement. And from day one, we've been working together. To give you an example, the first samples that were sent to Dakar were blood. We are not laboratory experts. We don't collect samples. They do it. We just tell them this is what is happening and this is what we want, and they do it. They collected the samples, they packaged them, and then sent them to Kotu. And then we coordinated how these samples will be transported to the Pasteur Institute in Dakar, which is the WHO reference laboratory. So they do that, and then when the results come, each of us will have copies of these results. So we are working closely together. What I understand is, yes, they have their capacity, but they also have their challenges at their level, which they can best explain. But we know some of them, and some of their challenges, in fact, affects our services as well. Yes, thank you very much.
Yes, you can go on.
So with regards to the figures that you're presenting in your position paper, are you telling us it's the same with the figures that they have in their position paper with regards to samples collected and then cases identified? I don't know. Because what we've received from them, we have it with our secretary, and then you were bringing other figures. So I just wanted to confirm whether they are the same. If we have differences, then that will make our work very difficult. It means there is no consistency in terms of how you operate with them. I don't know.
I expect the results to be, the figures to be the same. That's my expectation. If it does not, then maybe it depends on at the time we were developing the document, and we may not update, or they may not update, either or. But we are working closely together. That I can assure you. And it's not only on AKI, but a lot of things that are ongoing at the moment, and that have passed as well.
Yeah, just to confirm, with regards to the sample sent to, I think they have informed it's 57. It's the same number with regards to the sample. Yeah. Are you okay, Honorable? You still have further questions? Are you okay? Hmm? Some no.
But you need to affirm it.
No. Who want to come in? Yes, before you do so, please can you take the affirmation? Sir, can you please help us? Somebody want to come in who have not sworn in.
AKI cases. I think probably this is what the lab must have informed you. So I don't know whether they equally informed you of the tests they conducted or not AKI case. Thank you. I rest my case.
Thank you very much, Mr. Is it Nyasi or Kalisa? Thank you very much. We can confirm to you all the information that the lab sent to us is with us, and I can tell you some of these cases that have tested, sent in sample to Senegal definitely tally with what you submitted. So that's not a big issue. It's just wanted to confirm so that we can also, sometimes if you have evidence from this particular unit, you have another evidence from this particular, you need to make comparison and confirm so that you can adopt to one. And so that is the issue. So, honorable members, any other question? Yes, Vice Chair. Thank you. All right.
Thank you, Mr. Chair. Dr. Jame, right? Okay. I will start by, according to your submission, that we have 82 cases that are confirmed by the Ministry of Health. That is when it comes to AKI, and 70 of them passed away. So meaning 12 of them are still alive, if I am right. And in that case, are they still undergoing treatment or are they already cured? Going further, you did mention about when the team started the investigation. I will also want to join my honorable colleague, because whatever submission is being presented to us here as committee, we realize that everything started since July in terms of cases in this country. Do you want to also tell this committee that since July up to date, the issue of AKI is under investigation? We still cannot have a solution, and we still cannot come out to the public and tell them this is the exact situation that we are faced with and this is the cause of the situation. And to me, it is long overdue as far as the entire situation is concerned, because whatever information we receive from stakeholders is like investigation is ongoing. Investigation is still ongoing, and we still cannot come up with solutions. When some of the stakeholders will tell us that samples were sent to other countries for testing, and results were provided. So why can we come as a nation and tell our people that this is exactly what happened? And we see the way forward in terms of making sure that it will never happen again. You did mention it, that the last case that you had or received, as far as the case is concerned, that is the AKI case in this country, was the 5th of October, if I am right. Up to date, you have no cases or related cases of AKI according to your records. So meaning something is being done by the ministry. So what is being done is what we want to know. This is what the people that we represent want to know. I think it is high time for all of us to take the bull by the horn, to come out plain and be very open to the people. Because there are a lot of misconceptions that are really happening out there, which is very unfair to all of us, both the Committee of Health at the Parliament and also any other stakeholder that is also doing the investigation. Because for me, I really can't understand an investigation that has started since July, and now we're in November, still we cannot have a simple results as far as our investigations are concerned. I think it's high time we do away with such. And I believe if we can do that, if we can work together, we can make it happen. Because for us as Parliament, as committee, we really don't have time. We really don't have time. So in that regards, I will just want you to see how best we can come up with the realities. We must talk to our people. They must understand what we are doing, and they must also know what we are doing. So, I want to say, and I just submit, to be honest.
Thank you very much, Honorable Vice. Yes, you can go on. You can go on.
Thank you. Thank you so much, Honorable Vice Chair. One thing also we need to take note is our role as a committee, as a body. We are mandated to do an inquiry on the AKI cases. Most of the comments perhaps will fall under recommendation when the committee is done with the job. So some of these things perhaps will come under recommendation, even if they do not want to come now. The recommendation will force them to come, and I think they will be able to relate those information. Even if they don't want to, they will do it. Just for us to also be mindful, because I know a lot of people also are watching, and and then they are foreseeing the recommendation of the committee when the work is done. That is for my honorable vice.
Yeah. Thank you very much. Thank you very much. Thank you very much. Thank you. Thank you very much. You had the opportunity, I think, twice. I'll give you, but not now.
That's exactly.
You have it funny.
You know, the neurologist was here. The neurologist.
Sorry, honorable.
Nephrologist, sorry.
Yes, let me just observe. It is important we make references to evidence given to us.
Okay. This is
but
what I'm
as a matter of procedure and process, we should also be mindful of some of these revelations.
Okay.
Because the committee have not made any decision yet.
Okay.
We are doing the inquiry. You can make reference to a submission to substantiate a point. That's very fine. But as far as evidences are concerned, you have a limit where we need to stop until we are done. We make a decision out of it.
Yeah, thank you very much. This is the same in line. You people are telling us at the time it was a peak. Medicines were withdrawn, control C's, case, pam. No more case. The other person also tell us the same thing. High control medicine, high read, pam. Finish. Cases are not coming anymore. And yet still we cannot come into conclusion. Let's release the medicine again and see whether the case will come. If the cases are not coming, the signal. Thank you. I just want to. Thank you.
Yes, thank you very much. That's your observation. You want to observe? We are pressing
Yes.
time.
Doctor, I am back again. This time around, I just want to observe something as far as the position is concerned, in terms of some of these technical wordings. If you can also help the committee, because we are not scientists, if you can help us to better describe some of these difficult or technical words, it will also help in terms of at least putting our report together. Thank you.
Yes, thank you very much. Thank you very much. We can give you to say maybe out of the comments that we have made, because some of them are not questions. Probably you can also make your final comment before we adjourn.
Thank you very much. I just want to make it very clear to this committee that that may happen in the country, which we are doing. Whether there is AKI or no AKI, we are doing something. Along the line, we come to see strange things to happen. We conduct our investigations, and then we give feedback to our next level supervisors. Like in my situation, I report to the Director of Health Services, who reports to the Minister of Health. I also made it very clear that we are using the Public Health Emergency Operations Center, which uses an incident management system. And this is a coordinated way of responding to emergencies. In this situation, the minister has the last final say that if there is an outbreak, he declares the outbreak. If the outbreak is over, based on our technical advice, he declares it over. So we understand your situation, and we have taken note of your plight, our plight, and we'll continue to make sure this is looked into accordingly. That is to you, Vice Chair. And to the rest of the members, whether there is AKI or no AKI, I would still emphasize we are conducting our routine surveillance to make sure whatever comes, we are able to get it. And this is why when the EFSDH was struck by something that is very unusual to them, they had to inform the Director of Health Services. This is all part of our surveillance system strategies, that we need to be notified in any way. The information could have come from the community, it could have come from a health personnel, or it could have even come from a National Assembly member. We are available to get information that we need to verify and then respond to when the need arises. Thank you very much.
Thank you very much. Program, is it coordinator or program manager? Coordinator of the Epidemiology and Disease Control Unit. And thank you very much, Doctor. Is it the incident manager? And likewise, all the other stakeholders present here. We really appreciate your time. We really appreciate your responses. And then, above all, I just want to make it clear, the National Assembly Select Committee on Health will continue to perform its oversight mandate over the Ministry of Health and the department and agencies under our purview. This is unfortunate that our first instance have to be like this under this AKI, but as you know previously, and then as our oversight calendar dictates, the Epidemiology and Disease Control Unit falls under our purview, and we might call you at any moment to also have dialogue with you, have reports from you, hear from you, some of the challenges you have faced. And then we see how best we can pave a way forward to make sure that you are well resourced, you are well capacitated to perform your function. Because Epidemiology and Disease Control Units, as they call it in the America, CDC and so on, these people are very important. They are responsible of conducting surveillance in any case that happens here. And their presence have been felt, not today, during the coronavirus, the previous committee, we know the engagement we had with them. So thank you very much, and on behalf of the committee, we thank you so much. I know we might need additional information, but we will always reach out to have those additional informations. And in the meantime, some of the technical terms that are highlighted in the report, if you go back, just please help us define them. We can give you the number of the secretary. You can share it with her via WhatsApp. That suffice. And we will print it out and then share it with the general committee members. And then also a concern have just been raised whether the 12 cases that have not died, are they under treatment still or not? Just by way of information.
The 12 cases were discharged. None is under treatment currently.
They are all discharged. Thank you very much. So thank you very much. There is just one issue also that arises during the issue of the vehicles, as far as the issue is concerned. We will take it. We will see how best we can contact maybe the Ministry of Health and see how best we can maybe find a solution to that. Because as an important unit as this, you cannot be there without having mobility. If that is so, definitely your functions and activities will be jeopardized at one end. But we will take it up with the ministry and see how best we can talk to them. And I understand there's a bigger problem to what you just said. So we will take it up with them, inshallah. So thank you very much. And then on behalf of the members of the National Assembly and on behalf of the Committee on Health, we want to thank you once again and appreciate all that you've said here. And I can assure you all the evidence that you've given us, we'll make the best use of it. And also by way of information, any information that you gave to the committee, there is no competent court or court of law in the Gambia that nobody can call you and prosecute you based on that. You are well protected by the laws of the land. So I just want to assure you so that you can feel comfortable and feel safe. So thank you very much, honorable members. That is it for this morning session. So now you are released before we close our meeting. You are released. Thank you. Honourable members, please wait. Okay.